So knee pain in total knee replacement is again a dilemma, or how to interpret and how to examine these patients. All these patients would have had plain film radiographs, CT, but they have been inconclusive and they could not find out the cause. And the common cause, as Gopi said, it could be infection and it could be mechanical, it could be osteochondrosis, or it could be degenerative. And what he said is exactly correct. Patellofemoral is the most common, and you need to look at it as critically as possible, because we normally look at the planar images, we look at the patella, we ignore it, because in back of our mind we say, oh, this is very common, so we don't need to mention it. Well, in order to look into total knee replacement, again, I will stress you need to know and you need to discuss with the surgeons what sort of prosthesis they have put, what sort of reaming they have done, and what have they resected. The anatomy already been covered, and we are going to talk about the anatomy tomorrow, isn't it? Yeah, tomorrow. So I will just skip those. In 2012, there were about 90,000 knees and 86,488 hip arthroplasties were performed. These are the national statistics, and approximately 18% of patients had pain following total knee arthroplasty and 12% after hip arthroplasty. Again, the same, I'll skip this. Again, this is very important, and we need to stress this again and again, that you need to have a proper history, identify the cause, yes or no, then what modality you need to choose. It is very important. Again, you've got extensor mechanism, infection, stability, loosening, malposition, patellofemoral pathology. You need to basically, the history guides you and the clinicians guides you what needs. This has been already covered. I'm just going to be very quick. Somebody asked about the protocol. This is a standard protocol we follow, and you can use it with slight tweak here and there with the KV and MA adjusting on the region of interest. So nothing much different. So we use GE's D670 hybrid 16 slice SPECT CT. Yes, the same protocol. Now the important thing is you need to know whether it's unicondylar, unicompartment. So we'll talk about the anatomy. So when you are describing a knee joint or whichever joint you are going to describe, you need to describe it according to the anatomy, the relevant anatomy. So as a radiologist, I would prefer, when you talk about tibia, you have got medial plateau and lateral plateau. It's plateaus. If you're talking about the sides, those are the condyles. People normally put as medial condyle, lateral condyle is a misnomer. Again, the femorals are the condyles. You've got epicondyles, condyles, and the articular surface, trochlear. So we'll talk about. So it's unicompartment and bicompartment. So long prostheses, these are custom made. So it goes into femoral and tibial to stabilize, and unconstrained and mobile. So basically you've got these pegs there, it stabilizes. No pegs is unconstrained. So you need to know these, because then you're looking at the abnormality accordingly. Then arthroplasty, you're looking at cemented, basically femoral and tibial, no cement, and hybrid, no cement and cement. So you need to know what sort of arthroplasty is being done. So skip that. So again, this is most important. Again, I have to stress, when you're looking at CT, you need to adjust. So this is a spectrum. This is 1200, 4000, 6500, and 14,000. So in 14,000, you have basically discarded the artifact coming from the metal beam hardening. You can see it nicely, isn't it? It's like streak coming out. But here you can see the outline. You've windowed it. You can see the space. You can see the cortex, and you can see the metal prosthesis. So again, now you've got a planar image, you've got three-phase bone scan, and you're looking at increased blood flow and increase in the delayed images. So this is a typical example of any volunteers? There is some fluid in the suprapatellar. There is lucency, there is edema there. It's a hypersensitivity reaction because you've got patella, you've got femoral, and all these joints are increased with some edema reaction into, so it's inflammation all around, which is causing increased uptake. Again, unexplained right knee pain, got increased uptake, low-grade suspicion of infection. Again, looking at the three-phase. And CT will also give you an impression when you are looking at the CT, you have got adjacent soft tissues. So you can look into the soft tissues, which can give you an ancillary findings of infection. Like infection anywhere, you'll have edema, you'll have fluid, you have hyperemia. So all these will add to your conclusion. So it will be easy for you to say that it is infection or whether it's just loosening. Just skip through. So this is a patient, if you look at it, you can't make out what's happening. These are the screws embedded into the tibia. One of the screws show increased uptake, and the coronal images shows, and this was loosening of this. This is very early loosening of implant. This high riding patella showing increased uptake. I think probably we'll do this on the images tomorrow. I will conclude here because I'm ahead of time, or I'm behind time, sorry. Conclusion: understanding the biomechanics is the key to accurate diagnosis. SPECT CT overall decrease false positive, less equivocal results, and increased specificity, and reach alternate diagnosis in about 40% is quite high. Thank you very much.